in that catheter, they're larger than the catheter I use, but they are still small, regardless. The point of that is it's very easy for them to get clogged up with particulate matter, with blood, and it's also very easy for them to get occluded by some of the tissue deep in the ventricles. So that's why they are circumferential, so that if one side gets blocked off, you still have another like 1 or 2 or 3 sides that are still draining, okay? But that's why sometimes just to let you know why we troubleshoot the way we do. Sometimes you'll call me and say that the catheter is not draining, and I'll actually tell you to clamp it. The reason I'm telling you to clamp it is to reestablish that fluid column all around the catheter and unocclude. If it's sucking up against a leaflet of tissue, it will now build up a fluid column so that it's not sucking that tissue. Okay, so the key of the ventricular catheter and the drainage system in general and measuring an ICP is to have a fluid column. That's it. That's the science. So basically, you just have to have a continuous fluid column, and it's only then that you'll have a drainage and you'll have a waveform, which I'll show you. Okay, so my catheter is smaller caliber. The holes are somewhat smaller, but not a massive difference. The smaller caliber is important to me because flow and flow velocity is actually inversely proportional to the diameter of the catheter, or the radius of the catheter. So a smaller catheter is going to have higher pressure, higher flow. It's harder to clog that off and get the stasis issue than if you have a big hose, which basically it seems counterintuitive. It seems like a larger caliber should be allowing you to drain off more, but it's really hard to maintain that velocity that you sometimes need with some of these patients with IVH and etc. Okay, so that catheter in particular was developed primarily for trauma patients. A little counterintuitive to me, but anyway, primarily for trauma patients and also for bleed patients. It is pretty reasonably good when you use it in the subdural space, and I know this is always a source of questions. Dr. Rothschild likes to use that catheter in the subdural space, and it's fine for, can you pass it back up, Jess? It's fine for those, for that reason. Because again, you have a limited length along the catheter, which is actually going to give you that negative pressure if you're dropping the Vitarbo, which we'll talk about. So this is less traumatic potentially than, for example, I use the JP drains in the subdural space. It's a larger caliber, it's a stiffer catheter, it has a greater potential for injury, especially when you're inserting it. Okay, I think it works better in the long run though. Any questions on the catheter? Okay, so you guys don't have to deal with this part obviously, but you can see at the tip of the catheter, there's this connector. There's actually a couple of connectors. These are kind of critical and specific to the catheter, so they're not interchangeable. So if I have a hissy fit because I dropped the connector, just know to go get me another catheter, and don't ask why. Okay, so this is the Becker system. Basically, it comes in the package just like this. Usually we handle it, so you guys don't have to worry. That being said, a lot of other hospitals, just in case anybody goes anywhere, a lot of other hospitals the surgeon will actually expect that this catheter tubing is primed, okay? I do it here, I think Rothschild does it here. Most of the time you don't have to worry because if you're putting in a catheter for most reasons, a patient is going to fill up this tubing with their own CSF regardless. So you really don't have to prime it. The patients you absolutely have to prime it in are patients who have aneurysms. Those patients we really want to limit how much we're draining initially, so we're a little OCD. So you'll see, if and when we have an aneurysm patient with an unsecured aneurysm, you'll see me put in that catheter and clamp it off within the first couple of cc's. Whereas most of the time I'll let it just drain because it's increased ICP that I'm treating. For aneurysms, you're worried that there's a pressure gradient that you're creating by rapidly draining fluid, CSF, is now going to cause your aneurysm to re-rupture, okay? So in those cases, this absolutely has to be primed because we'll clamp it almost immediately, okay? So, I'm going to establish my fluid columns, because again, this is very fancy plumbing. That's really all it is. Now, I don't know what Dr. Rothschild does. I can only speak for myself. I rarely use these syringes when I'm setting up a ventric. I know it says sterile, preservative-free. I don't believe it. I don't care. This looks so flimsy, and every time I look at this, I'm like, nah. So I will almost always use the unit dose salines, and then I'll have it available to flush here. So I can flush with the unit dose preservative-free saline. I can flush proximally, and I can flush distally. I would obviously be very apprehensive if I'm not feeling super confident that this is a sterile product. I'm clearly not going to flush proximally, right? So that's the reason why I do it. So this is the fluid column I will establish. So basically, I just make sure it's off to the bag. I make sure it's off to the transducer, which you would be connecting later. This is the collection chamber. At the top of the collection chamber, you'll notice, I'll pass it around, you'll notice that there's an air filter at the top of the chamber. This can never get wet. If this gets wet, the entire system fails, okay? Which that is one of the things when people don't realize that, and you know, I'm getting calls at 3 in the morning because my drain stopped working after a trip to CT, for example. It's usually because somebody put this down on the bed next to the patient, they never clamped off the drainage, and now my filter is wet. But how do you explain that to somebody who doesn't even know that there's a filter? It's kind of a problem. So this is, that is critical. So usually when I do my priming, I'll go proximal, and I'll go distal. So the idea with the priming is obviously to get all the air out of the system, but at least get fluid coming up to your transducer. So for this one, for example, I'm not quite there. Usually we draw up 10 cc's anyway, but I knew these were smaller. So that's the purpose, though. You want a continuous fluid column at least to your transducer. So now that's plenty. I got a little in the chamber. We're all good, okay? So I usually leave a syringe attached here until I'm all done, just in case I have to do any other flushing. It doesn't have to be done that way. You can put the yellow cap back on, it's no big deal, but usually that's the way I do it. All right? Assistance. So, now the big debate I know is going on about how do we zero. And I have been challenged time and again about the zeroing nonsense. All right, so imagine my little catheter is in my burr hole here. It's obviously in the fluid column. If my water bottle was smaller, it would be in there. Okay. So now you're going to have your transducer at the level of the tragus, right? So as long as we're not draining, this could be anywhere, right? It doesn't matter. But if you then so again, 0 is tragus. That's where it's always got to be, unless it's in the subdural space. Okay. Even in the subdural space, I would argue that you leave it at the tragus level just for ease and consistency, but I can't force that to happen. Okay, so your 0 is at the tragus. So now, here's where the transducer is going to be connected, right? So if you connect your transducer here, you flush it, right? No more pressure bags, you just flush your transducer. You connect it here. If you turn off to the patient drainage, where is that fluid column now connecting? It's now connecting to your chamber, right? Via this air filter, so long as it's intact and it's not wet, that air filter is open to the atmosphere, right? That's what zeroing means. So you are now open to atmospheric pressure. So if I have this at 0, and have that off to the patient, my fluid column is now straight to air, okay? So you don't need to remove any caps, you don't need to, that is your 0, okay? So it should always work. Now, if it doesn't work, there are times where it doesn't work, so why wouldn't it work? It might not work if you have a wet air filter. Certainly not going to work if you're not actually at the proper level, which is an issue we could talk a little bit more about, especially with the squirmy patients. Okay, and it's not going to work sometimes if you have air bubbles, like there's a little air bubble here. Sometimes you'll see a dampening of the waveform, so sometimes you will just have to allow, like reopen everything, allow a little bit more drainage to occur, to make sure you have a continuous fluid column and there's no air bubbles. Okay? So between the different methods, if that's the case, if this air filter is atmospheric pressure, basically both of your methods of zeroing should give you the same result. Okay? And then finally, the ultimate way to check is to do a manual ICP. So the way I do my manual ICP is I'm off to transducer. I now have the fluid column coming from patient to my chamber, right? So you could see there that there's somewhere in the tubing you'll always find a meniscus. So, you'll more than likely have an air bubble you could follow also. But you'll probably find a meniscus, and if it's an alive patient that's not brain dead, they will have pulsations in a waveform, right? So you will see those pulsations in the fluid column. You should see those pulsations unless they have crazy high ICP or they're brain dead, or your catheter just is totally screwed. If you then start to raise up the chamber, you will start to see that fluid column backing off and going retrograde towards the patient, okay? If you then drop it again to say another centimeter of water pressure to lower, you'll see it start to slowly advance, okay? That's your manual ICP. A lot of people, you know, it's very funny because does anybody teach you guys that really?
I've never heard that before.
Right.
I know that normally it drains the amount over what your resistance is set to equal your ICP for the...
So that's a good point, Jess. So this is how I choose where I'm going to set that resistance, because I want the resistance to be slightly lower, at least slightly lower than what I think the ICP is, right? So if I think the ICP is 10, I'm going to set the resistance at 8, because then that'll promote drainage, okay? And like I said before, the biggest issue we really have is maintaining this fluid column and not letting it clot off, okay? We're not letting it get blocked. Go ahead.
So if you're going retrograde at 16 and you're draining at 14, then you could say your manual ICP would be 15,
Yep.
theoretically.
Mm-hmm. And then you flip it over to the transducer and see what your transducer is. They should typically be within a centimeter water pressure or two, or, you know, a millimeter of mercury or two, depending on how you have it set up. So they should not be that far off. If you're getting a manual of like 30 and your ICP is reading, you know, 10, maybe check your level and all that good stuff and say, because there are some, now I say this should all match, there are some patients with really low compliance that you will not get it to back, you know, do retrograde flow. So sometimes in those situations you're scratching your head going, you know, holding the Vitarbo up here and you're like, what the hell is their ICP? But, you know, sometimes it's just really low compliance. They have slit ventricles and you'll never get it to backflow, okay? But that's essentially how, when you guys call me and say, listen, I have this, I'm not draining, I think the catheter is dislodged, or I think there's a problem with the drainage system, one of the first things I'll do is I'll come in and assess that fluid column. Because again, it really is just antiquated plumbing. It is just a fluid column. So if the column can go back, it could go forward, then I know it's a patent column, okay? Then I have to figure out why your ICP is saying 60 when I really am getting a very different number, okay? So the manual ICP is, and I'll tell you, if you go to a true neuro ICU and you don't do a manual ICP, you will get your butt chewed off like in the first 10 minutes you're there. Because you're going to call somebody and you're going to say, you know, my catheter is not working, I have no waveform, blah, blah, and somebody's going to be like, well, what's your manual? Say, what? Okay. Because that is, you know, you do have to realize this is a very antiquated system being connected to these monitors that are supposed to be high-tech, but there's always issues with the monitors, right? How many times do you have to change a cable? And that's all it is. And so I'll come in, I'll do my manual ICP, and I'll be like, something's wrong with your cable, or we need a new Vitarbo because this filter is probably wet, or something of that nature. And that just reminds me, do empty your Vitarbo when you're getting somewhere around the 50 mark, or else you will get burned. If, you know, anybody who took care of bed 2 for any period of time while he was here, you would know that 1 hour he could do nothing, and the next hour he would dump like 50 cc's like that, okay? Well, if he dumps 50 cc's like that and you leave it alone, he could easily dump another 30 cc's and then your filter is wet and then it's non-functional, okay? So that's just words of wisdom, so to speak, from somebody who's been burned many times.
May I ask quickly, if
Yep.
our filter is wet, since there is no filter to change, is it okay for us to, are we allowed per policy or whatever to disconnect turn our patient off from their drain, prime a Bureautrol, hang it, and connect the patient? Or is that something that the neurosurgeon has to do?
Right. I would argue that
I know I've done it, is what I'm saying, not here, but.
right, exactly. I mean, that is certainly part of nursing responsibilities in a lot of neuro ICUs. I would say here, since it's done so infrequently, just save your behind and call the neurosurgeon. I think it's just safer that way.
Especially because you have to do that sterile, right? 'Cause you
All
have
this has to be,
open that up and all
anytime
that.
even if you look at my catheter, I want a mask on, I want sterile gloves, I want you to lay down chicken bones and do a little voodoo chant.
I wish it's like
How do you
that
want
with
us
the other
to-
one.
What's that?
I wish it's like that with the other one.
Yeah.
What do you want us to use to prime the
The
transducer?
problem.
They're gonna-
That could, so in theory, your transducer fluid should never be making it to my patient's brain, okay? However, you always have to assume that it may. So it's always gotta be the same. Preservative-free saline is the rule of the day. It is the only thing that can be used with the ventricular catheter. Okay?
So it's not the water then?
It's the purple
I think
one.
that
It's in the
we-
neuro-
Oh, I
it's in
just
the
had a
neuro-
seizure!
Yeah, I think that-
It's the purple.
It's got that yellow cap or whatever.
I think that's the.
Do you give neuro patients water?
No, but I'm just, I'm
Because
saying
I've
that.
had pharmacists before asking, can I have some preservative-free saline, and they've told me there's no such thing.
I just
Okay.
opened the neuro card.
So
Or
number
draw it
one.
out of a bag?
Now we're depending on pharmacy.
Right.
Maybe don't film this
Yeah.
part. I have had days, especially a Saturday, where I waited 3 hours for preservative-free saline. And the wrong product kept being brought to me until finally I lost my mind and broke into the neuro card. They are on the neuro card, so that's the important thing.
Okay,
So just break into the neuro card.
okay.
But there is absolutely a preservative-free saline unit dose. It's a 10 cc vial. That's
So it
usually,
looks like that, but it says on it that it's preservative free.
It's like
It's
the.
got
it's the
little green
small
cap.
10 cc
You have to,
vials.
like, you draw
Right.
it up.
Okay.
Right. And you'll see, it's actually a little box, colored box, that it says preservative-free.
Okay.
What's that?
Is it purple?
The traditional one was green. Now I think it has a pink top. Yeah, mauve. I don't know.
The
Anyway,
purple is the water. In the neuro cart, the last time I was in there are the green vial top ones. They're like a lime green.
yes, no water for the brain, ever. No matter what anybody tells you, unless somebody's on the verge of death and, this is a last straw, but no water in the brain. Now, that is theoretical because basically the brain has, the CSF is the composition of saline. Okay, so if you put 5 cc's of water in, you're probably thinking, it's just 5 cc's. The whole volume of the ventricular system is about 25 cc's. Okay, so you've significantly changed the composition very quickly, and the brain doesn't like that, especially an injured brain doesn't like that. So that's that. Okay, any questions about the zeroing? Anything?
Will you go over the manual zero one more time, Dr. Vitarbo?
Sure. So if you have the fluid column, again, have it off to the transducer. Obviously, all the other ports have to be open. So what I usually start at is, where my resistance, where I've had the resistance set, right? So say I have my resistance set at, well, our favorite number is like 10 and 8, okay? So I have my resistance set at 10. And they are draining at 10,
Okay.
okay? So then I'll start raising it and start to see when this fluid column, the meniscus, starts to backflow, okay? Now I know this pressure has to be higher than the CSF, the ICP, or else it wouldn't backflow, right? So then I'll drop it back down. So say the backflow started at 14, okay? So then I'll start to drop it again. And say I get to 12, and it's usually when you get to the manual ICP, the true ICP, it won't go forward or backwards. You'll just start to see the pulsations at the top of the meniscus, okay? That's your ICP, okay? And then when you're done with that, then you put it back to 10, which is where I had it as the resistance, because then, again, that's going to allow a small amount of continuous flow. Okay. So the other, and you guys may have seen it, Jess, I'm sure you saw it at UF and stuff, but the other way to manage these drains, and I'll tell you the pros and cons of it is to open it up kind of on an as needed basis. So you'll see an order, keep drain clamped, so off to flow, measure the ICP, so I actually have the wrong line, sorry. Measure the ICP, and if the ICP goes above 20 for 5 minutes sustained, then you open it to drain. And typically we'll say, open it to drain for 5 minutes at a resistance of 10, and then clamp it again. Recheck your ICP, okay? So that's a pretty standard order, and that's a pretty old school way, traditional way of managing these drains. The benefit of that is you have a true measure of ICP more continuously, right? So that's a good thing. The bad thing is like I mentioned before, you do have to maintain some degree of flow in order for this fluid column to remain patent. Not in everybody, but you don't know who that patient is that you're going to lose your fluid column and you're going to lose your drain. The patients that we typically will put that order in on are the severe head injury patients who have slit ventricles, okay? Because like I mentioned before, if you're draining some of the, even though those are small holes in the tip of that catheter, sometimes the leaflets of the ventricle will actually get sucked in and occlude the tip of your catheter, okay? So if that's happening, like I said before, I would have you turn on, clamp the drain to reestablish a fluid column, so now you can get a waveform and measure the pressure. Yes, Jess?
Just to clarify, a slit ventricle is like a compressed ventricle
Yeah.
from the brain injury.
So basically you can barely see it.
Right.
You'll see sometimes when I'm about to put in a catheter, I'll look and be like, this is going to be dodgy, let's see if it gets in. Sometimes you can't get it in. And sometimes you can only get the smaller catheter in. But those are the patients that we will typically write to just open at PRN. That being said, guess who are the patients with the highest ICP? It's those patients, okay? So typically you're going to be cursing me out because you're going to be draining every 5 minutes. And you'll be like, just leave it open. Okay, so if we just leave it open, then we have ongoing drainage. We theoretically have treatment for our increased ICP going on, but then we really don't know the ICP, right? On a minute-to-minute basis, okay? So that's why sometimes you'll see that I'll have a patient with a ventric and then a camino. So the Camino gives me my continuous number. The Ventric gives me the treatment, so everything's copacetic. Until the two numbers start not to match and you guys are calling me, freaking out. My ICP by the Camino is like 22, by the Ventric it's 18.
How do they measure differently? Where is the Camino tip?
The Camino tip's in the parenchyma of the brain. So what number do you think I'm going to tell you to follow?
The Camino. Oh, the Ventric, okay.
This is the gold standard. As long as you have a
The one that's closer to the
waveform,
brainstem.
as long as you have a waveform and you have a good fluid column, this is the gold standard. Okay? Why not the Camino, Jess? Either one of you.
Because I'm like, what?
Right. You asked, you said the
Um,
Camino, so why not?
I was just thinking because of the location of where it is and because and I was thinking because the Ventric, obviously, you were saying could have more issues as far as is it clogged, is the filter wet, so I was just thinking.
Right, but if
maybe
you have a
can't-
good waveform, it
you
all
can't
depends on
treat
if
from
you
the
have a good
Camino.
waveform. Okay? A fiber optic is a fiber optic, it's tubing, okay? It can crack, those fibers can fray, they can crack. That's why you have drift over time. It all depends on how it gets put in. When you guys, go to CT, that bolt will keep it somewhat secure, and that silastic sheath
Okay.
on the outside keeps it somewhat secure, but it cracks.
Okay.
Okay, so basically that is technology. So technology is great until it stops working, right? So you can't necessarily depend on the Camino all the time.
Okay.
Okay?
So I don't know if I've seen you do it, but how come sometimes a Camino, a patient gets a bolt but doesn't get a Ventric?
So that should, in my opinion, that should be the rarity
Okay.
or the exception to the rules. So for me, I will usually put in a Camino if I think you actually are not going to have an ICP issue. Okay, so I'll go to the Camino if somebody like comes in polytrauma, their GCS is 7, they have DAI on their scan. There's pulmonary issues, so you need to keep them paralyzed or sedated. I'm not going to have an exam, right?
Mm-hmm.
So for those patients, I will put in a Camino because about 20% of patients with DAI will actually have an elevated ICP,
What's DAI?
diffuse axonal injury.
Oh, okay.
The other 80% do not have an elevated ICP,
Okay.
okay? So I'm putting in the Camino just to capture that 20%. Then if you are in that 20% and I can't keep your ICP controlled with fairly modest intervention, you'll probably be changed out to a Ventric.
Okay.
Or you'll get the Ventric added as well,
Okay.
okay? There should be really no patient, with few exceptions, who has a Camino who's running true elevated ICPs in the mid-20s and above that doesn't get either a Ventric or some sort of intervention. Now, the exception to the rule sometimes is, again, the patient with the slip ventricles that, while 99% of the time we could get a catheter into those ventricles, they won't, number one, there's the 1% that you can't get it into, and number two, the Ventric won't always work, okay? So then you're left with the most definitive intervention, which is going to be, is this somebody who's a candidate for decompression?
Okay.
And that's not always the case. Go ahead, Jess.
When you say true elevated ICP, do you mean somebody who is intubated, sedated, in bed, unstimulated, has an elevated ICP?
What I mean, yes, that would be one of them. But what I mean is, if you're not thinking, remember I mentioned the Camino shift,
Right.
they crack, they fray. So if you're really believing your Camino number, and you don't think there's a technical issue with the Camino, and your ICP is elevated, then something else needs to happen, okay? Sometimes that something else can only be hypertonic saline, sedation, paralytics, to get the number down. If that's all you need to do, that's fine, okay? But if that's happening on day 1, you're gonna have a long week. And everybody's gonna be very unhappy, and there are gonna be a lot of phone calls. If that's happening on day 3, because edema peaks at days 3 to 5, thereamouts, okay? If that's happening on day 3, that's anticipated. So you say, all right, we got a couple of rough days ahead of us, you know, let's amp up our intervention. Whereas if that's day 1, you're screwed and you're going for decompression if you're a candidate. Or you're starting the talks of, this is really bad. Okay? Anything else?
I have one question. Like, I've
Yep.
had orders where we do not have a bolt or a ventriculostomy drain, and the patient's like GCS low, but they're wanting to give mannitol, but they don't have anything to monitor it with.
So,
why-
so it depends. Sometimes it depends, because I'll do that as well. Sometimes that depends on what the pathology is and what you're seeing on imaging. So we're not necessarily asking for you to monitor anything. Those patients, you know, perfect example is a patient that comes in with a contusion. They will develop, some of them will develop life-threatening edema around that contusion. You know that's going to progress over 5 days or so. And in some of those patients, they're borderline GCS. So sometimes you'll just throw a little something at them to get them over that hump without needing the drain. Because you still have an exam. That doesn't apply to somebody who's a GCS of 6 and you're doing that with. That's somebody who's like a GCS of 8 or 9 who's right on the cusp of meeting criteria for a monitor. And you're like, it's day 3, it's day 4. Let me do some conservative stuff, which is what I would do if the monitor were there anyway.
Okay.
So it's a little bit of trying to forego an unnecessary procedure or a procedure that's only necessary for a day or 2.
Okay.
So is it worth it? Who knows? But I personally, I'm sure you've noticed, I prefer hypertonic saline. I think it's clearly easier on the kidneys. I think you can fine tune it a little bit more in terms of your sodium control, whereas the mannitol, using mannitol is actually a science which a lot of people have not mastered, because for anybody who's done nursing for any period of time, back in the day, we used to give mannitol and just follow the serum osms and the sodium. And you would be stable, 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 and then all of a sudden, and you're like, how the hell did that happen? How did my osmolarity get to 330? Like, everything's wrong. So basically, over, the past 15 years or so, there's been a greater appreciation for the lab changes, and basically we do a gap need and look at different factors other than just the sodium and the osmolarity. Okay, so you need to follow really the gap difference to figure out how well you're using the mannitol. Okay, so if you're not going to do that, then it's like pointing a gun at someone, because you don't really know when you're going to go off the rails with your mannitol. Whereas with the hypertonic saline, you guys have probably noticed, even if I use a 23.4% solution, after a dose, I'll have a change of maybe 3 or 4 points in the sodium. It may stay up there, it may drift down a point or 2, but it's not like going from 135 to 150 or 145 to 160, okay? And it makes people nervous, because I'll even say, like 153, go ahead and give them a dose. And then people are like, what? We're going to be at 180 in a second. No, it really is, the body is a bit more clever than that, okay? Whereas the mannitol, you really are kind of driving the kidneys And then we have patients on, especially back in the day, patients on Vanco and Gent, which were killing the kidneys, and then you're throwing mannitol on top, and so then they're on CVVHD, and you're like, how'd this happen? That's how it happened. Okay.
Can you re-emphasize while we've got this group here, care of this patient, oral care, turning, clustering, all of that stuff?
Cluster
please.
care, my favorite.
Please.
Okay, so again, this will primarily apply to the severe head injury patient, but I strongly suspect we've really not paid as much attention in terms of, with respect to the stroke patients. They probably suffer the same kind of like dysregulation and irritation to our interventions. So for the patients with the elevated ICP, you will notice, obviously, sometimes you'll just walk in the room, you're doing nothing, you walk in the room, especially when there's a Camino, and like their ICP goes from 18 to 23. And you're like, I didn't even hit a button yet, okay? And then you'll turn around and walk out, and it'll go right down to 18, okay? Never mind the whole noise, people talking, coming in to examine, etc. So the theory with cluster care is you want to limit those moments of stimulation to the bare bones minimum. Okay, so you have to do oral care, you have to clean them up after a poop or whatever, you probably have to turn them. So before ever doing those interventions, you go in, depending on what the surgeon tells you is their poison of choice, but let's say, for example, I usually use Dilaudid. I'll say go hit them with 4 of Dilaudid, assuming their pressure can tolerate it, which usually they can. Go hit them with 4 of Dilaudid 10 minutes before you're going to go bother them, okay? And then you give them their injection, you walk out, you wait your 10 minutes, you go in, and then you start your whatever care you have to give. If you see that your care is driving up the ICP, driving up to the low 20s, I'm not going to freak out about it. I could look at you the wrong way and your ICP could go up to the low 20s, but if you're saying, oh, we went in to give them a bath and the ICP went up to 50, I'm going to lose my mind, okay? So for me, cluster care is critical, and then you have to reassess and triage based on how that patient responds. So what I'm going to say, and this might not be in jive with everybody else, but what I would say is then you backtrack to what's the most critical for that patient. If they're laying in poop, cleaning the poop is critical, okay? If they need to be turned, that as long as they settle back down after their turn, that's critical. What is not critical? Giving them a bath, making them look pretty, braiding their hair. Those are not critical interventions. So those are the ones that need to fall off the quickest when you're having ICP issues. And usually it's for a matter of a couple of days where you're really running, even when it relates to turning, for example. It's usually a couple of days that it's really potentially a problem, and the rest of the time it's probably going to be okay. Okay? But cluster care is huge. And then there's the whole issue of limited stimulation. So if you notice that, just walking into a room upsets a patient, then, family has to be kept to a minimum. Lights have to be off. Noise has to be kept to a minimum. You have to respond immediately to an alarm going off, because if it's bothering you, it's like exponentially worse for them.
So in the patients who don't recover quickly, they take a while for their ICPs to go back to normal, what are your recommendations for care for them?
So, number one, then you reassess what your cluster care preventative was. So if you gave 2 of Dilaudid, should next time you try 4 and see how that works. If
And
that,
you know all baths are at night, and you're getting a phone call for that.
Well-
Increased Dilaudid.
no, that's it. That's the point. My point is that a bath does not need to occur for a few days.
That's what I
If
wanted
you
to
have
hear
an
you say.
uncontrolled ICP and you have an EVD, when you can pre-medicate, when you lay your patient down, the EVD is there for a reason. You re-zero it, you open it up. Same thing with CAT scan. You should never lay your Buretrol on the patient. Once you have readjusted your patient on the stretcher, on the table, you realign your EVD and you open it up. Don't never leave the unit with it clamped. Go to CAT scan, lay them down, put them back on the bed, take them back to the unit, then realign and open, because you are going to have an elevated ICP that you could have prevented.
Right.
I think part of the problem is too, is that people are not realizing that it's gonna go up when you're messing with them. But if it comes back down, we're good. But if you're watching it and you're in there for that few minutes and it continuously, even though you've medicated them, no, you don't wanna give them a bath. But yeah, shove a pillow under them and get out of the room. You know, I mean, that doesn't mean we can't turn them, that doesn't mean we can't do oral care, it doesn't mean, you know, that we can't do those things that still have to be done for that patient, which I think is freaking people out because, oh my God, I walked in there and it went up to 40. Well, you can run in and run out and then not mess with them again for several hours.
Right, and the other point is that, as I mentioned earlier, we look at sustained ICPs.
Right.
You get to know your
If somebody
patient.
coughs, if you're suctioning somebody, if you really are looking at the ICP, it'll probably go up to 40. If I suctioned you, your ICP would probably go up to 40. So they're no different. But if it's just during that immediate insult, the immediate time of that insult, that's not a big deal. Okay.
Well, I think what Jessica was alluding to as well was that when you're doing all that, don't clamp it through the entire thing.
Right.
3, 0.
The ventricular drain is your friend. It's there for a reason. So the worst time to ever not have it functioning, whether or not it's because you turned it off or because it stopped functioning, is when you're messing with a patient. That's absolutely when you depend on it the most.
So for clarification while we're all here, Camino, transport to CAT scan, do we unplug, do we not unplug?
The box or
The fiber optic from the monitor.
I've actually had it done both ways. I don't have a problem with it being disconnected at that hub. You know, the cord to the box. I don't have a problem with that. You know, just has to be done carefully. I mean, lugging that box is a production, especially when you have a monitor and everything.
Mm-hmm.
So I don't have a problem with
Okay.
it being disconnected. But like I said, I'm not a huge Camino utilizer regardless, so maybe I'm not one to ask.
Yeah.
Has this been an issue? Should I guess
No,
it's been an issue?
there's just a lot of question as to whether you can unplug them and not, or not. You know, like, does it need to be re-zeroed, which I know we re-zero with placement, so it's hard to, you can't re-zero
It can never be re-zeroed once it's been placed.
Right,
Because it's being
but it
zeroed to
doesn't
the
need to
atmosphere.
be re-zeroed. When
No.
we unplug it, we can reattach it.
Correct. As long as it's the same box.
Mm-hmm. So don't get a replacement box.
Typically no. Usually, usually it's at the most critical aspect of it is, or when we're zeroing, you know, is obviously you've done the connection. I have to change the nut, right, to get it to 0. Well, if now it's a different box, how do I know where that screw head is?
Mm-hmm.
So that's not necessarily 0. Because if I really wanted to, If you have somebody with a Camino whose ICP is 30, I could go change that screw head and be like, oh, look, it's 10. Okay, so the box is the key. That connection is the key.
Camino ICP reading negative numbers.
It's dysfunctional. There
Even
is no
when-
negative.
I'm just asking because I know these are questions that I get when I'm
Yeah.
down there and we have all this, so. ICPs read
You
negative
cannot
numbers.
document a negative ICP.
No, of course not, but at times, so eventually their ICP goes up a little bit, your waveform returns, and you have,
Then, right, then there's a technical issue with your Camino, and hence the validity of your measures is questionable.
so is it necessarily the fiber optic cable that's in the parenchyma, or could we theoretically get a new Camino, have you zero it, and reattach it?
No, it can never be re-zeroed once
Okay.
it's in parenchyma, because it's gotta be to air. So basically you would,
You have to take it out.
basically you would have to take out the whole thing. And in which case, you're not gonna reinsert that one,
Right,
you know, you may, if you're lazy enough, you may choose not to drill another hole for the 3 seconds it takes to do that, and put another screw, but that would not be the best thing for the patient. That would not be the right answer for the board exam.
I like
All right,
How long do they last? Is it like a few days?
the Caminos.
Yeah.
Caminos, the company literature will say that the drift doesn't start until like day 7. And they actually talk about a millimeter of drift every day or so.
When you say drift, it means just like the movement of the inside.
The inaccuracy of the number. So if my ICP is really 8, it might be 9 on the Camino, it might be 7. So it could go either way, hence negative numbers sometimes. So I don't really believe that, Rachel. I think it is a bit sooner, but usually I'll start to get antsy at day 7, thinking it's got to come out soon. And sometimes that is why we make decisions to remove it, and you guys think we're insane. Because it's like, the ICP is 24 and you're taking it out. Yeah, but all these other parameters suggest to me that the ICP is not really 24, and I have a clinical exam now, and I know drift is occurring.
Right, so it may not be accurate.
Correct. Right. So I don't want people treating an inaccurate number.
You're treating the monitor.
So usually, if you get to day 7 with somebody that has increased ICP, usually from trauma, usually at that point, you could really start to think about removing monitors, okay? There are obviously the exceptions, you know, who had Eric Johnson with me. He was gonna torture me until day 14, you know, and I did a craniectomy, so he's like, taking you out, I keep you up for 2 weeks.
Is that a motorcycle guy?
Yeah, that was
Yeah.
the one.
I seen him the other day. He was
No,
in the-
he's in North Carolina.
Okay, maybe not then.
He was the one
He was
in
in the
5
5.
for a long time.
He was one that we did, like, no
Was
stimulation
he
at
the
all.
one from Texas, right?
No.
No.
Oh.
Is that all good?
He was.
No, that guy was in
Yeah.
4 for a while.
Exit out.
How's he doing? Do you have any idea? Can we?
I don't know, he was doing pretty good.
I tried to
for that
Facebook
for-
and stalk, but there was,
Because I know he went back to
Talking about
Houston.
Jason?
Yeah, right before the hurricane went there. So
Oh,
I
really?
wondered if he got swept away.